So yeah, Rebecca's gone through a great presentation on how we identify, measure and value costs as part of an economic evaluation. This presentation will look at the other side, so how we identify, measure and value the outcomes. Just a few objectives here. So first of all, we're just going to explore the wide range of impacts that can arise from health problems, both health and non-health impacts. Then we're going to identify the different ways of how we may measure health and non-health outcomes. Then compare different approaches for valuing health and non-health outcomes. And then we're going to explore how all that interacts to really impact on our choice of economic evaluation and the policy questions that we are trying to answer. So first of all, everyone in the room here, we're all trying to alleviate health problems, but they come in different forms. You know, not all health problems are the same. Some of us work on addressing disease, like cancer. Others work on injury, like force prevention. Or others, you know, like myself, I've worked a lot in obesity, so a risk factor for either disease or injury. Also, health problems can be manifest in different ways. We might just look at the effect of the health issue on someone's physical condition, look at morbidity, the presence of disease, or mortality. But then other health problems can cause, you know, significant emotional distress, or have impacts on social difficulties in isolation. And a lot of health problems can also have quite significant financial and economic impacts. So it does make it challenging because we can't really compare all health problems equally. They all have different impacts, and we have to consider all those in an economic evaluation. Additionally, this can be seen at different levels. There's obviously the impact on the individual, but there's also flow-on effects to the family and household. We saw Rebecca talking about quite often people need carers, people taking time out of their day to care for their loved ones. But also it does have impacts on the local community and the rest of society. As such, I always spoke about, health can be measured in several ways. So we can consider mortality, like the number of deaths averted or number of life years that might be gained from an intervention. We can look at morbidity. We look at how many cases of disease or injury are occurring. Or we can explore the impact of an intervention on someone, on the severity of the disease that someone might be experiencing, or their quality of life. There's also intermediate measures. Like sometimes it's not possible to measure actual outcomes within a clinical trial, particularly for things like prevention, where we're investing to prevent things from happening. We can't really capture those outcomes from happening. For example, I've got a link here. Blood pressure is known as intermediate measure for risk of cardiovascular disease. So we might want to measure the impact of a blood pressure lowering drug as opposed to a case of cardiovascular disease. There's also process measures. So there are activities that are known to or believed to have a direct bearing on the outcomes that are achieved by the intervention, such as a length of hospital stay or having a correct diagnosis. And then there's also monetary value of health, and including the impacts on an individual's productivity. As Stephen spoke about earlier, there's economic evaluation takes different forms. I've listed 4 of them here. I've deliberately excluded cost-consequence analysis, so don't worry about that. But as you can see, what's common to all of those is they all involve costs, as Rebecca went through. Each economic evaluation, you need to identify, measure, and value the costs of your intervention and your comparator. However, they differ by how you identify, measure, and value those outcomes. Also, different types of economic evaluations answer different questions. So in general, you do an economic evaluation because you want to demonstrate the value for money of your proposed intervention. But that's efficiency. But efficiency has 2 levels. So we can talk about allocative efficiency, and that's the idea of, is something worth doing? Do the benefits of this intervention exceed the costs? But then there's also another level, which is technical efficiency. So once we've decided something is worthwhile doing, what's the best way of providing it? And it's really how you frame the question what efficiency you're looking for. So if we're considering whether screening for colorectal cancer is worthwhile, we might want to look at that allocative efficiency part of our economic evaluation. But if we decided that's a good thing to do and we want to work out what's the best way of providing it, then that's looking at that technical efficiency. So again, the different types of economic evaluation will answer different efficiency questions. So in general, the type of economic evaluation you might choose to do is really dependent on what outcomes you attempt to measure and value and what efficiency questions you're attempting to answer. Just going to pause there. Did anyone have any questions so far? Great. So what we're going to do is we're going to work for a few examples. We're all going to pretend we're health economists for the day. And we're going to choose what type of economic evaluation we would choose for these different scenarios. So the first scenario is the Ministry of Health have come to you and they want to compare the costs of receiving intravenous antibiotics in a hospital with the same treatment delivered at home via a healthcare service, home healthcare service. Okay, so I've got a little flow chart here just to help us, and we're going to talk through this together. So first of all, what's our intervention and what's our comparator? Does anyone like to state what they think each is? So what's something that's new and what's something that's usual care?
Either the patient coming to us or we go to them.
Yep, great. So let's look. Do you think there's good evidence of effectiveness of the intervention? Do you think like IV antibiotics have been well researched in the literature? So yeah, I think there's pretty good evidence out there. We're going to work our way down. So we think there's good evidence. Is the effectiveness of those interventions equal? Do you think getting IV antibiotics at home will be the same as getting IV antibiotics in the hospital? Yeah. So
there are kind of complexities of it, but if you look at it overall, it's the same treatment, it's just in a different setting. You know, at home, you're not going to have an IV drip running 24/7, potentially. You know, there are the risks of doing that at home. But when I'm thinking about this, I'm thinking, let's assume that they're kind of the same. What we're looking at is the different setting.
Absolutely, yeah, absolutely. Agree with all of that. So you're right, like the dose isn't changing, the mode of delivery is not changing, it's both IV, it's just the setting. We would expect that the effectiveness would be equal, it's just the setting. And if we went back to the question, it kind of, explains that. They want to compare the costs, they don't really talk about the outcomes per se. So that's right. So we would do a cost minimisation analysis. So with cost minimisation analysis, we're comparing the costs of alternative courses of action, so having the IV antibiotics at home versus in the hospital. And we're not ignoring the outcomes, we're just have assumed that they're going to have an equivalent effect. So we're just really comparing the cost from one or the other. And that's useful because I guess, healthcare system, we have scarce resource, we've only got so much money to spend. If this model might save some costs, that might guide decisions from healthcare administrators to change models of care.
I just want to make sure this goes in to my brain properly. So the intervention is not the drug. The intervention is the model of care. Therefore, on that flow chart, when you said, was there a equipoise in terms of effectiveness about the model of care, isn't the answer no? Therefore, it's a costing study?
I think, is there good evidence of the intervention? So I guess the intervention itself is the IV antibiotic. It's just the setting that you're delivering it in. So you're right, you might think that, no one's... in an ideal world, you think, IV antibiotic, it should be the same. But if you're considering other things like, compliance and that kind of thing, that might create a difference in effectiveness overall. But we're just looking at the the effectiveness of receiving the antibiotic in terms of the outcomes, the resolving infection. That's going to be the same. It's just how cheap it is to deliver that outcome. Yeah.
I just want to play a bit of a devil's advocate here because potentially the IV delivered in hospital, because there are higher costs associated with travel and all that, may have a lower level of compliance. And therefore maybe you might want to question the... I know the terms of reference of your study are different, but I guess when you're doing a cost minimisation study like this, the assumption of equivalence in terms of outcomes is sometimes, may be questionable, particularly for something like this where there are shifting costs onto patients and where you might see a drop-off in compliance.
Yeah.
And in this case, are we going to take into account the patient experience, or is the Department of Health not really interested in that? Like that. I mean, yeah. I mean that in the nicest way. It's
absolutely like the effects on quality of life, and it could definitely it'd be a difference. That might guide what choice of economic evaluation, which we'll get onto afterwards. But yes, in this case, we've kind of just simplified and saying we're just looking at whether that infection resolved. We're assuming it's the same. We're just looking at that where it's delivered and if there's any difference in cost there. Yeah.
Would we also look at volume of delivery? So in a hospital, you may get through, 50 to 100 patients, depending, but driving across town, Sydney traffic, maybe 10 to 15 if you're lucky. How do you work that in?
Absolutely. So as Rebecca was mentioning, you quantify transport time as a cost for that home intervention. So if you that might end up being more expensive. We don't know. We'd have to analyse that. Yeah.
The other thing to add is that question of volume is a really important one. When we're looking at cost effectiveness, because we tend to work with the average. That volume question falls out a little bit unless we're talking about specific aspects of the care delivered that might impact on the efficacy. So in this example, it might not be such an issue because we're not assuming that you're going to have differences in rates of compliance or differences in rates of people accessing care. It might be if you then work those factors in, but the absolute volumes, that's really going to be a question about how much it's going to cost us as a society. So not necessarily about that question of cost minimisation per se at the average level, but in terms of delivering this service to all the possible patients, and that's a slightly different question. So that's that question of budget impact, which Steve alluded to earlier today.
Great. So we'll move on to our next question. So the Ministry of Health, obviously not during that acute COVID stage, but post-COVID, maybe earlier this year, they wanted to come to you and ask for an economic evaluation to compare two different diagnostic strategies for COVID, rapid antigen tests and PCR tests. So what's the health problem being addressed here? Are we talking about treating COVID or diagnosing COVID? So what measure would you be using to assess the effectiveness of PCRs versus rats? How would you measure what each are doing? Yeah, number of cases detected. So you've got two interventions. Obviously, you've got one's more resource intensive, one's less resource intensive, more convenient, but you then sacrifice costs for accuracy. Is there good evidence of the effectiveness of the interventions being compared? I think they're very well researched, so yes. Is effectiveness of intervention equal? So again, effectiveness, we're talking about COVID diagnosis. Accuracy, I'd say no. Some might disagree. Can all outcomes be valued in monetary terms? Can we put a monetary value on a positive COVID diagnosis? No. Absolutely. We'll get onto this later. Like monetary value of health is still in its infancy. It's still a bit controversial, so it's not something that we commonly do in health. So I'd say no. Can a positive case of COVID be measured as does that affect your quality of life?
yes.
So the disease itself might affect quality of life, but the diagnosis, yes or no, does that affect quality of life? Possibly, yeah, yeah. But essentially, like, yeah, how we're going to measure the effectiveness of two is, does it detect COVID? Yes or no, the accuracy. So you might be stretching a bit, but yeah, we that's how we'd analyse it. So we talk about it being in natural units. That's our outcome. So I would pick a cost effectiveness analysis. So the outcomes are measured, yeah, in natural units. We don't have a specific valuation of that outcome. The valuation is implicit. Like, the more accurate that test is, the better. So therefore, it can answer that technical efficiency question. We want to be able to have tests out there. We can accurately diagnose COVID. We just want to work out what's the best way of doing it. Is the extra cost for the PCRs worth the better accuracy that it provides? But because it's measured in natural units, it does make it hard to compare these cost effectiveness results between different interventions and different disease areas. Like, if it's, you know, just put up a number, $2,000 per case of COVID detected for a PCR, how do you compare that to another intervention that might look at a case of cancer detected? Can you compare those two? How do you do that? And you can't. And that's why it can't really answer that question about allocative efficiency, you know, because those outcomes aren't measured in the same way. We'll move on to our third question. So the Ministry of Health wants to compare the costs and outcomes of two interventions that treat early stage breast cancer, mastectomy without breast reconstruction, compared to breast conserving surgery and radiotherapy or breast conservation. So is there good evidence of the effectiveness of intervention being compared? I did a little literature search the other day, so there's plenty of studies out there. I think we can say yes. Is the effectiveness of interventions equal? Do you think they would have the same outcomes? No. When we think about outcomes for cancer surgery, what outcomes might we consider? Mortality, so survival or life years gained. Anything else? Morbidity, a case of disease. How about quality of life? Yeah, I think quality of life, especially in this specific example with the two different surgical techniques, would have quite an impact. There is literature out there saying that women that have the breast conserving surgery have quite significant improvements in quality of life. So quality of life is really important if we're going to measure the difference in effectiveness between these two interventions. So can outcome be measured as quality adjusted life years? Yes, we can do that. So we do a cost utility analysis. So in a cost utility analysis, your outcomes are measured as quality adjusted life years. The quality, it combines your length of life or survival and quality of life, which is termed utility, in a single measure. Utility or health safe preference values are how we value health-related quality of life, and they're measured on a scale between 0, which would be death, and 1, which would be perfect health. And they represent the strength of individuals' preferences for different health states. To calculate QALYs, utility values for a health state are multiplied by the duration of time in years that a patient spends in that health state. So just got an example here. So this is individual. So we're looking at their last 14 years of life. So you see for these first 4 years of life, they're in 100% perfect health. So in that first kind of section there, that would be 4 QALYs. Unfortunately, they've been diagnosed with an illness, maybe underwent treatment. That utility of where their health state is now after surgery, after treatment, has been reduced to 0.7. They live another 5 years in that health state, so they've had surgery, they've recovered, they're in remission. They're functioning reasonably well, so they live 5 years at that 0.7 utility. So instead of 5 years, then that would be equivalent of 3.5 QALYs. And then, unfortunately, the disease has come back, that their health further deteriorates, so their utility now is only 0.3 on that scale of 0 to 1. And they spend the final 5 years of their life in that state. So they spend 5 more years of life alive, but in terms of QALYs, that's only worth 1.5 QALYs. So in total, the patient survives from that kind of point in time onwards for 14 years, but that's in the equivalent of 9 QALYs. Did anyone have any questions about how we calculate those? It's pretty simple maths. Now, how do we obtain these utility values? I haven't gone into too much detail here, but essentially there's 2 methods. You can directly measure them from patients or indirectly, which is more common, especially in clinical trials. And the way this is done is that there's a number of what we call quality of life instruments out there. So these are questionnaires which are completed by patients. There's generic ones that kind of cover 5 main domains like mobility, pain, whether they experience anxiety, depression, and also their ability to perform their usual activities. So the patients would complete these questionnaires to describe what health state they are in across those domains. And then we have these algorithms that are applied, and it converts their questionnaire responses into our utility value. The algorithms have already been developed, so they're sourced from samples of the general population. So the general population we surveyed, and there's a range of methods they do it, but essentially they respond to a range of questions about the different health states and their preference for those health states, and then that converts the questionnaire responses into a value between 0 and 1. Any questions about that? So cost utility analysis can be used to assess technical efficiency. We decide something's worthwhile doing, what's the best way to do it? A certain price for a quality gained or at a cheaper cost. Because we have a common health outcome, this means that we can, cost utility analysis can be used to address allocative efficiency within the healthcare sector. So going back to Stephen and Rebecca earlier about the Pharmaceutical Benefits Advisory Committee, so that lists drugs from the government under public subsidy. That's given a set portion of the healthcare budget. So because we're measuring different drugs, they all measure the same health outcomes. That information can be used to decide how to best spend that money. But what represents value for money? And as Stephen mentioned earlier, there are a couple of threshold values. An implicit one in Australia and an explicit one in the UK. And just to point out as well, I think it's been mentioned a few times, but the fact that we don't have an explicit threshold in Australia is actually quite helpful, and especially through the lens of equity, because quite often what's most efficient, what's the best value for money for society, actually exacerbates inequities in society. So especially in minority groups that experience disproportionate burden of disease, what's best for the majority might disadvantage them further. So the fact we don't have an explicit threshold is good because they can approve drugs that are beyond that threshold if they might improve things like equity. I've thrown in a slide about disability adjusted life years here, so you might have heard this term used before. They're similar to QALYs, but not the same. They've been developed as part of the Global Burden of Disease Study, so the AIHW, when they do their burden of disease reports, they use DALYs. So while QALYs represent the sum of years of healthy life lived, DALYs represent the years of healthy life lost due to premature mortality and years lived with disability. In QALYs, we use utility weights. DALYs use disability weights, and essentially they're the inverse. So a disability weight of 0 would mean perfect health, and a disability weight of 1 would mean death. So it's the inverse of the utility weights we use for QALYs. But those weights are sourced, or they're based on expert opinion, as opposed to QALYs represent society's preferences for those health states. And they're intended to be universal, where for the utility weights, they're sourced from country-specific surveys. So in Australia, we've done samples of people to generate utility weights, or algorithms have been developed to convert utility weights from other countries into an Australian value set. You could use DALYs for your cost utility analysis. You won't get exactly the same results as QALY, but they are quite similar. But they're not commonly used in Australia for economic evaluation. And we'll come to our final type of economic evaluation, So the Ministry of Finance would like to know whether it is worth investing further resources into obesity prevention programs at a school, or to build a new cycleway nearby for active transport. So I guess both of these things could potentially help in terms of obesity prevention in childhood, which would be really important. But they're different, and how would you compare the two? I would ask, who would fund each of those projects? Do you think health would fund building an active cycleway? The department, no. So it's like more infrastructure. And how easy is it to, say, do a controlled trial of an active cycleway and measure health effects? Is that quite, very difficult. So, so it would be very difficult. Probably the flowchart won't work as well in this case, because essentially that would kind of lead us to a costing study, which you could potentially do, but for the active cycleway. But the government kind of would like to see a comparison between the two. This is a very hypothetical scenario, but just in terms of the obesity prevention program at the school, do you think there's kind of good evidence of those kind of interventions in the literature? There's plenty out there. A lot of them don't show a lot, but again, that's prevention. You don't see a lot in the short term. You might need to model kind of flow and effects from that into the future, but there's plenty of evidence out there. Could you value health in monetary terms? Do you think we can do that? We can. We can. It's a bit controversial. So the cost-benefit analysis, we're going to value these health outcomes evaluated in monetary terms. And I guess in that question we're asking is that cost-benefit analysis is quite routinely undertaken in infrastructure capital projects. And it's from a social welfare perspective. You just want to make sure that the benefits are going to outweigh the costs of any proposed project. But if we're looking for that kind of trying to answer that allocative efficiency question, is something worth doing within our scarce government resources. It does make a very difficult comparison. But if we were to value health in monetary terms, we can then compare those results against the cost-benefit results from other sectors of the government. So if government's looking at a wider lens of how best to spend all their money, they could use that for comparison. There's different ways that we value health. There's a human capital approach or willingness to pay approaches. So I'll speak about human capital approach first. So Rebecca did mention about productivity losses, and essentially these methods are the same. It's based on the expected earnings of an individual, and it's a measure of their loss gain productivity. So what you do, you quantify the time that individual might miss from work, and you multiply that by their wage or the market rate for what their job is. It is lots of ethical issues with this. It really disadvantages people that are in lower paid jobs or doing things like unpaid care, mothers, things that we don't have a market kind of wage rate for. It disadvantages children. We don't have any kind of value on a market wage for a child or the elderly. So there's lots of equity issues if we were to use this method. As well, we don't value things like leisure time, things that are important to people's well-being. And we miss a lot of intangible costs as well. Like we can't put a dollar value on quality of life. So things that are important to health that we're not necessarily valuing. The second approach is a willingness to pay approach, and that values a health outcome based on an individual's willingness to pay for that outcome. There are different methods to do this. This revealed preferences method, people analyse real-world data and they look at how people compensate their wages for improvements in safety. So say, for example, you compare the pay of a miner versus a factory worker, and you look at the difference in wages between those two professions and you multiply that by the risk of injury in both those jobs, and then that kind of gives you a willingness to pay value, so what people are willing to forego in terms of their lost wages or reduced wages for improvements in safety. Other methods are stated preferences, which are obtained from survey questions. So there's this contingent valuation survey. So people just asked to state what they'd be willing to pay for a specific good or a change in amount or quality in terms of their health. And there's also discrete choice modelling, which I think Stephen spoke about earlier, which individuals respond to different choices, and there's a trade-off in terms of a monetary value as well. Willingness to pay feeds into this idea of a value of a statistical life. So that's someone's willingness to pay, given their income, to avoid a risk of their health, and that can be translated into this value. Just to make a note, this is not a value on someone's life or on any identifiable person, it's a statistical life. So current estimates in Australia are about 5.1 billion. And then that can be translated into a value of a statistical life year of about 222,000. So these are updated annually based on inflation. So yeah, that could be a monetary valuation if you could demonstrate your intervention could reduce your risk of mortality. But there are a number of assumptions again with these methods. When we report cost-benefit results, different to the ISA, we use this idea of a net present value or a benefit-cost ratio. And essentially, it's just trying to identify, do the benefits outweigh the costs? As I mentioned earlier, in theory, a cost-benefit analysis is great because it provides most information to government if they want to make decisions about how best to spend their scarce resources. But it's still not commonly used in healthcare due to those methods I've spoken about. They're still in the infancy. There's still some controversy about some of those methods. In health, they've most commonly been used to assess large capital development projects like health facilities, though I do know that in New South Wales Health, like Treasury does have guidelines on how to do cost-benefit analysis, and they're also trying or mandating now that that's also applied to things like public health programs. So yeah, it's a growing field, but still got a way to go. So just in summary, we've got our 4 different types of economic evaluation there. So they all measure costs between different alternatives, but they differ in terms of the outcomes that they're accounting for, and also what questions they are able to answer regarding technical or allocative efficiency. And that would be it. Do we have any questions at all?
Yes. Thank you very much. I was wondering about the logical relationship between the outcome and the type of model evaluation. So for the utility analysis, only qualities could be used in cost utility analysis. Is it true?
You could use DALYs, but yeah, in general, it depends who's asking the question. So for the PBAC, they request for any new drug that you present a cost utility analysis. So that requires it to be presented in qualities. If it's just in the literature, you could present that as a disability adjusted life year. But as mentioned, like DALYs are used, but more to measure burden of disease, not an economic evaluation. Yes.
Thank you. To follow, also only DALY and quality could be used in utility analysis. Is true?
Yes. Yeah.
Oh, good. Because in your the distinguished tree, the final one is it the outcome quality? So it's actually the quality or DALY.
Quality or DALY. Yeah.
Okay. Thank you very much. Just want to confirm that.
Right. Great. And
we sometimes look at cost avoidance to compare options. So when we do that, which technique are we technically applying? I'm not quite.
Cost avoidance. I'm not too familiar with that. I'd imagine you're. Yeah.
So let me weigh in, and I think Virg is also going to weigh in. So one of the concepts that Rebecca talked about earlier when she was talking about the costing was looking at everything that happens to the patient whatever we're doing. So whatever our intervention is, whether it's a drug, some sort of physical technology, a model of care, we want to know about everything that happens to them in terms of their health care. That includes things that we might avoid. So if there are events that we're avoiding by treating someone in a certain way, we're going to capture that in our cost analysis. Yeah. So that cost avoidance is going to be picked up in our cost side. Then coming to what Joe's been talking about here in terms of the different evaluation methods, depending on that evaluation method, we might want to look at other aspects of what's being avoided in terms of if there's a quality of life effect, for example, then we're going to go to a CUA. We're going to do a cost utility analysis, and that might be the only point of difference. So we might be avoiding inconvenience to some people associated with a certain model of care, and we want to capture that in a cost utility analysis. The health outcome might be exactly the same, but there's a difference in terms of the impact to the patient in terms of quality, and we want to pick that up. Sorry, Virgin.
Yeah, no, I think you've taken the steam out of mine, but that's exactly what I was going to say. Maybe just to emphasise that the costing is the same regardless of the... so your consequences are things that are differing across these methods, but the costing approach is the same. And I guess to emphasise that the choice... for cost effectiveness analysis, you've got to be confident in one measure of effect, really, that you think is very important and would provide important information for both of the options you're comparing. And it is a complex thing. So for that example earlier about the diagnostics, well, at the Kirby where I am, people do a lot of work around rapid tests and point-of-care tests. And actually, rarely do they stop at the diagnosis when they're measuring an effect. They will want, because one of the real important impacts is actually time to treatment and getting people on treatment, especially if you're talking about rural populations and so on. So it's something that you really need to sit down with teams that you're working with and nut it out and spend a lot of time framing the intervention, thinking about those pathways of care that Rebecca had that neat diagram for. What are the relevant ones? And does it make most sense to our target audience, this particular measure of effect? Because if it doesn't, you're not really, producing something that's going to have much of a policy impact or practice impact. Thanks.
Hey, Dave.
Just a question about CBA. I don't know much about CBAs, but I saw the value of statistical life was $5 million, and the value of a statistical life year was 200,000.
Yeah.
So 5 million by 200,000 is about 25 years, which is way off life expectancy.
Yeah.
Is that a discounting thing? Or?
It's a discounting thing. So they get the value of statistical life is in the presumption that it's a young adult with at least 40 years to live, but that's got a 7% discount rate. So any future costs are discount annually, 7%. So hence the difference in the value. Yeah. And that goes back to Rebecca's discounting, that we value things present more than we do in the future. Yeah.
Thanks.
Can I just clarify? So in the case you were just talking about, which I think makes perfect sense, so if you do a randomised control trial and then within that you do an economic analysis, then you move it forward and you want to now implement it and translate that evidence, is it a different type of cost health economic analysis? Is it a different format, even though all the elements are still the same?
Yeah. Okay. From the healthcare perspective point of view, that cost utility analysis and valuing things in qualities is most useful because you can compare different interventions across the different disease areas, but that's not always feasible in different situations. And it really depends. Again, that kind of allocative. Do you want something new that's not currently done? Do you want that listed, or is it something that's already done, or are you looking to do it better? That's at technical versus allocative efficiency. So yeah, it's kind of defined by those two questions. And again, as Stephen kind of spoke about earlier, sometimes this is valuable information to assist decision making, but it's not a binary choice. It's not like you demonstrate something's value for money, then it definitely gets listed, and that's it. There's lots of other factors as well. Yeah.
Yeah, I mean, that's a great answer, Joe, but I just might add that, you have your trial-based economic evaluation. I missed Steve's presentation, so he probably already explained the difference, but you would probably be expected to complement that with some modelling that might, for example, the modelling might be scaling up to a larger population, and then you might need to make some adjustments to your costing, for example. So do some extra modelling, maybe over time, what would be the long run impact on costs and effects. And the other thing would be your policymaker, particularly your funder, would probably want a budget impact analysis combined with that. And I think Steve may have already mentioned about that, but that's about affordability. So what would it cost us over the next 5 years to roll out this intervention? Is it affordable? We know it might be cost effective. Is it affordable? Yeah, thanks.
I will talk a bit about the modelling in the lecture made this afternoon. That's essentially, Burgess just stole my thunder. You can leave early this afternoon.
Thank you for the talk. I just had a question about the idea of perfect health for the QALYs. Is that based on subjective or objective measures, or is it a combination of both to understand perfect health?
Perfect, yeah. There's a few different methods, but essentially it's individuals' preferences. So they're presented with two scenarios, well, in one method, two different scenarios, and it's their preference for each scenario. And it's their response to a range of those alternatives that determines the value for that. So essentially, based on those questionnaires, so the better responses, someone's indicating that they've got no pain, they've got no issues, individual's preference for that health state would be higher than if they're presented with a scenario where they've got pain, they've got issues doing their usual activities. So, and it's a trade-off. So in one particular method to do it, it's would you prefer 2 years in perfect health or 10 years in this health state where, you got pain and anxiety, and it's kind of, what you prefer, and then it's that trade-off between the two. That's how they get the valuations of it, yeah. And just to note, you can actually have a negative value, so you can actually be in a state or utility worse than death if that's in for certain health states, yeah.
I think I'm going to be wrapping it up. So can we say thank you to Steve, Rebecca and Joe? I think it's a fantastic morning. And thank you to all of you and your fantastic questions, and thank you for trying to remember to put them into the microphone. So I want you to try and do that even better this afternoon.